Today we will discuss the pharmacotherapy of hypertension for postgraduate physicians at College of Medicine, Maine University, and I'm Dr. Mina Kelleni. The objectives of our lecture is to understand the basic and clinical pharmacology of the different classes of antihypertensive agents, including mechanism of action, preferential indications, as well as adverse effects. Please focus on preferential indication as we will discuss many groups, but every group have some drug of choice indication, some better indication. So when I'm writing preferential indication in the objectives, just to take care that you will focus while you study this lecture, while you listen to which groups that we should give this or that class of drugs to. Let's begin by a small introduction. Cardiovascular diseases are known to be responsible for over 30% of all global deaths, a very huge number, and hypertension is the major risk factor of cardiovascular disease. So when we are talking about cardiovascular diseases in general and hypertension in particular, we are talking about a huge factor or a huge causation that is responsible for over 30% of all deaths all over the world. Moreover, suboptimal control of hypertension, and this is why we are going to update our information, that's to make sure we are giving our patients optimal control. And our patient knows that they are under optimal control, because suboptimal control of hypertension, the patient are taking medication, but the hypertension is not optimally controlled, is associated with target organ damage, like diabetes, by the way. If diabetes is not controlled, is not optimally controlled, we will find also target organ damage. For hypertension, the main target organ damage will be heart failure, ischemic heart disease, stroke, kidney dysfunction, retinopathy, vascular dementia, and aortic dissection, all of which are major causes of disability and premature death. Importantly, adequate blood pressure control, this is our goal from this update, from this lecture, reduces the incidence of acute coronary syndrome by 20 to 25%, reduces the stroke incidence by 30 to 35%, and heart failure by 50%. So please take care that you update your information for the best interests of our precious patients. Again, the lifetime risk to develop hypertension among those 55 years of age and older who are or were previously normotensive is higher than 90%. That's to say, hypertension may be called inevitable. If we get old, hypertension risk is over 90%. That's to say, inevitable for everybody, almost everybody. However, most diagnoses occur between the third and fifth decades of life. Between 25 to 50 years, most of the diagnoses of hypertension occur in this age group. Interestingly, about 80% of people with hypertension are aware of the diagnosis. This is, we are in 2021. I think 2 or 3 decades ago, we called hypertension as a silent killer. Now the awareness is global. Even the ordinary, even non-educated people know that there is hypertension and there is complication from hypertension. 75 are receiving treatment already, but look again to what we called previously as suboptimal control of hypertension. Control of hypertension occur only in 52% of the affected patient. And this is a huge, by the meaning of a huge problem that we should focus, we should challenge, and we should change it. In most patients, hypertension results from obscure pathophysiological etiology. So we don't know it exactly, okay? This is called essential or primary hypertension, which is the most prevalent type of hypertension that occurs in over 90% of patients. A smaller percentage of patients have a specific cause of hypertension. This is called secondary hypertension. And by the way, if we could treat this cause, the hypertension will be eliminated. So the majority also of newly diagnosed patients would require non-pharmacological therapy only to be followed up regularly. This is an important statement to see when your patient is newly diagnosed as hypertension. Many times, in most of cases in mild to moderate hypertension, we should not prescribe drug. We will go to lifestyle modification, which is called non-pharmacological therapy, just to follow up, because many of them will might need future pharmacotherapy. Then, who is hypertensive? I think this is the most updated definition worldwide. When home systolic blood pressure over diastolic blood pressure is about 135 over 85 millimeter mercury or higher, this should be considered hypertension, of course, after repeated measurements, because we don't consider it hypertension after only one recording, except if there is unequivocal insult, complication. But in all other cases, which is the vast majority, we need repeated measurements under certain conditions. Of course, you know it from internal medicine if you are an internist, or any other disciplines that you manage hypertension patient. So when repeated home systolic versus diastolic blood pressure is 135 over 85 millimeter or higher, this is called hypertension. To be noted that if it is in the clinic, it will be the classic 140 over 90. For diabetics, this is something different. Not only diabetic, we will also see other groups. Over 130 over 80 will be considered hypertension and must be managed because of the extra risk that diabetes inflict our patients. So diabetes and blood pressure over 130 over 80 more liable to many complications, so we must intervene. Again, notably in individuals over 50 years of age and older, over 50 years of age, the systolic pressure and the pulse pressure are better predictor of complications than the diastolic pressure, and this is also a huge change in our practice. About 1 or 2 decades ago, we have been told that diastolic blood pressure is the main indicator for complication, and we classified even hypertension according to the diastolic blood pressure. But things have changed, and we updated our definitions. So now systolic blood pressure, pulse pressure in those over age 50 are better predictors of complications than the diastolic blood pressure only. We have risk factors, including genetic ones, which are non-modifiable, and some modifiable like obesity, like smoking, which can influence the occurrence and development of hypertension. Moreover, complicated regulatory network, including the renin-angiotensin-aldosterone system, or the so-called RAAS system, the nervous system, also affects the progression of hypertension, and this was our introduction. We said that secondary hypertension has a cause. Secondary hypertension, if we treat the cause, the hypertension will be eliminated. So what are the causes of secondary hypertension? Let's classify these causes into 3 main groups: diseases, medications, and pregnancy. By the way, for pregnancy, some pregnant ladies got hypertension and they weren't hypertensive before, and this hypertension, or gestational hypertension during pregnancy, might disappear spontaneously after delivery, or sometimes it persists. For diseases, we have chronic kidney diseases, chronic parenchymatous kidney disease, Cushing syndrome, increased cortisone, primary aldosteronism, pheochromocytoma, increased adrenaline, thyroid and parathyroid diseases, coarctation of aorta, obstructive sleep apnea, renovascular diseases. Renovascular disease here is bilateral renal artery stenosis. So these diseases are known to cause secondary hypertension. If we, for instance, a tumor causing pheochromocytoma, and we could manage to eliminate this tumor by a surgery, then the hypertension will disappear. Otherwise, we cannot eliminate hypertension. For the medications that are causing hypertension, we have lots of medication, but I'm just mentioning the most important ones: amphetamines, sunitinib, sorafenib, anti-tumor drugs, bevacizumab, cortisone, cyclosporin, tacrolimus, pseudoephedrine, and cold medications, ergot alkaloid, erythropoietin, estrogen-containing oral contraceptive pills, chronic use of non-steroidal anti-inflammatory drug, testosterone, some antidepressant, venlafaxine, bupropion, and abrupt withdrawal of some drugs like beta blocker and clonidine. Use of monoamine oxidase inhibitors with tyramine-rich food. This might cause hypertensive crisis. And excessive consumption of sodium, licorice, or ethanol also may share in development of secondary hypertension. We mentioned that most newly diagnoses of hypertension are managed by non-pharmacological therapy, which is called lifestyle modification. What is this lifestyle modification, which is also the main target or the main tool that we use for mild to moderate hypertension? Lifestyle modification is recommended to all patients, by the way, even those who are taking the medication. It will help them and includes, but not only, first thing, weight loss for obese or overweight patients, and we might use the DASH diet. This diet for anti-hypertension is rich in fruits and vegetables, low fat and dairy foods, and low saturated and total fats. So decrease the fat in your food, increase fruits and vegetables. This is called DASH diet. If we stick to it every day, this will help us to control our blood pressure. And increase dietary fiber, lower blood pressure. For every 7 grams of dietary fiber ingested, the cardiovascular risk could be lowered by 9%. This is amazing, and we should all stick to this simple DASH diet and recommend it to our patients. Also, reduction of sodium intake. This is also lifestyle modification. Aerobic exercise, 30 minutes per day. And there is something interesting, which is the hand squeezing exercise. You might Google it or see some YouTube videos. 3 times a week. Also, we have some studies that they decrease the blood pressure by perhaps 8 millimeter mercury. And meditation and breathing control also work as non-pharmacological therapy. By the way, again, this is the most important examples of lifestyle modification, but of course there are a lot of other non-pharmacological lifestyle modification that have been shown to be effective in management of mild to moderate hypertension, but let's stick to the basics. Then, for some patients, we just diagnose them with hypertension over 160 over 100 millimeter mercury. Those patients, irrespective of the cardiac risk, need drugs. Okay, this is a consensus about this. Drug treatment is necessary for those who complain of a persistent 160 over 100 millimeter mercury blood pressure. So pharmacological therapy is needed. And again, in mild to moderate hypertension, let's say systolic 140 to 159, diastolic 90 to 99, we should begin with lifestyle modification. If no response, some guidelines say we should intervene with drugs, like the European guidelines. It is debated by other guidelines because we have, at least until now, no evidence that the mortality or risk of cardiovascular events can be reduced when we give drugs for treating mild hypertension. Okay, especially in low-risk individuals. Personally, I think, and also our Egyptian patients, they will complain. Most of them will not be convinced if they know from their relatives, from their friends that they are hypertensive, and we began with lifestyle modification. Unfortunately, they will ask and will insist that they will take drugs, so it's okay. We have other guidelines that say it's okay, and there is no absolute no mispractice if we prescribe those patients also drugs. But let's, as we will see in other slides, let's begin with the lowest possible dose and the safest as much as we can drugs. And you will hear this cardiac risk many times in this lecture and in other lectures. There is a famous American College of Cardiology and American Heart Association toolkit, online toolkit to assess the cardiac risk for anybody. And here is the link to it. It estimates, basing on age, sex, race, blood pressure, diabetes status, lipid level, and smoking. And there is also an N. For those with low risk, again, some guidelines say there is no need to give a drug. But again, even if you give a drug, you should stick to the lowest possible dose and the safer or the safest drug possible. Goal of our therapy to be less than 140 over 90 millimeter mercury, with some exception, as we said before, for diabetes. We will add high cardiac risk according to this tool, and also those who had previous stroke and we want to prevent its recurrence. This is called the stroke prevention. In all these cases, systolic blood pressure is preferred to be lower than 130 millimeter mercury. These are the antihypertensive agents that we will give you updates about. First, we will discuss the drugs acting on the RAAS, renin-angiotensin-aldosterone system, beginning with angiotensin converting enzyme inhibitors, angiotensin receptor blockers. We have also renin release inhibitors, beta-1 blocker and alpha-2 agonists. We have also renin antagonist. Also, there is dilator, vasodilator. We will discuss calcium channel blocker and direct arteriodilators. We will have diuretics, especially thiazide diuretic, but we will mention also loop and potassium-sparing diuretics. And we will discuss sympatholytic drugs, including adrenergic and adrenoreceptor antagonist, alpha-1 blocker and beta blocker, drugs that decrease the central sympathetic outflow, which are alpha-2 agonists, and other drugs like reserpine and guanosine. We will not discuss. They are rarely used, but there are some indication in which they might be used. But it is out of our scope for this lecture to you. This wonderful diagram, quoted from this reference, shows us what is the renin-angiotensin-aldosterone system. I will turn on the highlighter. Okay. Here is a renin. The renin is released from the juxtaglomerular apparatus from the kidney. The renin has one important rule, is to convert angiotensinogen into angiotensin 1. Angiotensin 1 is acted upon by angiotensin converting enzyme inhibitor to release angiotensin 2, which acts on two types of receptor, angiotensin receptor type 1 and type 2. And AT1 receptor will cause the well-known vasoconstriction, and AT2 on the other hand causes vasodilatation. Here is another enzyme called ACE2 will convert angiotensin 2 into what is called angiotensin 1,7. Wonderful angiotensin 1,7 has wonderful action inside the body, some of them by the mast receptors, which will cause vasodilatation as well. Here is aldosterone coming from the adrenal cortex, acting upon mineralocorticoid receptor and produce multiple physiological actions that will increase the blood pressure. So the drugs that will be discussed in this lecture regarding the RAAS, we have renin inhibitors, we have angiotensin converting enzyme inhibitors, we have angiotensin receptor blockers, and we have also mineraloreceptor antagonists. And one from Katzuk, our famous textbook that we use very often. Here is renin that transforms angiotensinogen into angiotensin 1, and for this renin we have renin release inhibitor and renin antagonist, renin release inhibitor, beta-1 blocker and alpha-2 agonist, and renin antagonist like aliskiren. And for the angiotensin converting enzyme, we have angiotensin converting enzyme inhibitors, and for the angiotensin receptor blockers, and they will antagonize the angiotensin action that is causing vasoconstriction and also helping aldosterone release. So angiotensin receptor blocker will antagonize both actions. And we have, as we said before, mineraloreceptor antagonists like spironolactone and eplerenone. They antagonize aldosterone action that leads to salt and water retention and increase the blood pressure. For angiotensin converting enzyme inhibitor, we have captopril and lisinopril, which are, by the way, both active drugs. Other drugs are mostly prodrugs that need activation in the liver before acting as antihypertensive. You know, prodrug and an active drug that needs first metabolism in the liver to become active and produce its action, like enalapril. I'm just giving a few examples, okay? Commonly used as initial medication in mild to moderate hypertension. And here is an important statement: relatively less effective in black and old persons, and also less effective in predominantly systolic hypertension. So please, this is a famous group of drug, often used, many drugs with lots of trade names, but you should not consider it as of a choice in blacks, in older person, or in predominantly systolic hypertension. Single therapy, many of these drugs control hypertension as monotherapy, not only ACE but other groups also, in about 50% of patients. But if we need a combination, we might use ACE inhibitor and a diuretic, ACE inhibitor and a calcium channel blocker, which are potent combinations. ACE inhibitors are agent of a choice. This is what we call preferential indication, okay? ACE inhibitors are agent of a choice in person with type 1 diabetes with frank proteinuria or evidence of kidney dysfunction because they are renoprotective, okay? Delay the progression to end-stage renal failure. Moreover, they are prescribed in type 1 and type 2 diabetes if there is microalbuminuria, even if those patients don't meet the usual criteria for antihypertensive therapy, and this is huge to indicate an antihypertensive drug for those who do not meet the criteria of hypertension. But because of this renoprotection, proved evidence-based protection, these drugs are indicated for this reason. So please focus on these statements or in these paragraphs talking about which groups of patients should take ACE inhibitors, and in every group we are talking about, please see which groups are better to be taken and which groups are better to be avoided in. ACE inhibitors are also drug of choice in patients with heart failure with reduced ejection fraction. Why? Because there is an evidence-based medicine that they are cardioprotective. As we have told you before, they are renoprotective. Now we are adding they are cardioprotective. They possess cardioprotective properties, and thus also indicated even in asymptomatic patients with reduced ejection fraction. Contraindicated in pregnancy. Adverse drug reaction include dry cough, kidney dysfunction, angioedema, hypotension, dizziness, hyperkalemia because they decrease the release of aldosterone, rash and dysgeusia. Some members have some adverse effect more than the others. For example, rash and dysgeusia are more common with captopril, which is a prototype of this group, but we don't know if currently we don't know if prescribed captopril. We have a lot of other members in angiotensin converting enzyme inhibitor which have lower adverse effects regarding the allergy and dysgeusia. Dysgeusia alter taste sensation, but all of them share, for instance, in the dry cough, all of them might share in kidney dysfunction in some patients. So at least in the start we should monitor the kidney function test. And this dry cough might also be bothersome in some patients to the extent that they should stop taking angiotensin converting enzymes. Fortunately, we have similarly effective but lower adverse effect profile group, which are the angiotensin receptor blockers. They are very similar to angiotensin converting enzyme inhibitor, but they do not increase bradykinin. They do not inhibit angiotensin converting enzyme inhibitor, which was degrading bradykinin, and thus angiotensin receptor blocker do not increase bradykinin, and which is associated with dry cough and angioedema. More might reason for the higher incidence of dry cough and angioedema and angiotensin converting enzyme inhibitor is because they increase the bradykinin due to their inhibition of angiotensin converting enzyme But angiotensin receptor blocker like valsartan and candesartan do not increase bradykinin, so lower adverse effect profile. Yes, some will persist like hyperkalemia, kidney dysfunction, but angioedema and dry cough are rare. Contraindication also in pregnancy, and there is an important statement here which was until recently very controversial and very arguable. Now please take care that combination therapy with an ACE inhibitor and an ARB is not advised, no benefit, okay? We had theorists saying this combination will help us and many other arguments, but again, currently many big entities, reliable, unbiased entities, are showing combination therapy of ACE inhibitor and ARBs is not advised. For the renin release inhibitor, we have beta blockers that we will discuss later, and alpha 2 agonist, clonidine and alpha methyl dopa, but their adverse effects are not little. Sedation is very bothersome, fatigue, dry mouth, postural hypotension, erectile dysfunction, and if stopped suddenly, hypertensive crisis or rebound hypertension, so not commonly used in our practice, but alpha methyl dopa is used in hypertension and pregnancy. We have renin receptor antagonist, like we have aliskiren. But again, please take care of this statement, focus to this statement. The combination of aliskiren with ACE inhibitor or ARBs in person with type 2 diabetes, as claimed by some authors and some companies, now shown to offer no advantage. Okay, so please avoid this combination. No advantage, and might even increase the risk of adverse cardiac and renal consequences. Okay, this is a very important statement to be taken care of. If you are given aliskiren, take care that its absorption inhibited by fatty meal, contraindicated also in pregnancy like the previous groups, and adverse drug reaction include angioedema, hypotension, hyperkalemia. Aldosterone antagonists include spironolactone and eplerenone. We discussed them in the lecture of diuretics, and we will also give you some clinical notes in this lecture. Let's move to calcium channel blockers. They are classified into dihydropyridines like amlodipine, nifedipine, felodipine, and non-dihydropyridines like verapamil and diltiazem. These agents act by causing peripheral vasodilatation. They, from their name, block the calcium channels in the blood vessels, and this will cause vasodilatation. However, less reflex tachycardia, less fluid retention than the other direct vasodilators, arteriodilators that we will discuss later. They are effective also and about as monotherapy in 60% of patients. Most of these groups, from 50 to 60% of patients, might work as monotherapy. But calcium channel blocker have a wonderful and an amazing advantage that they work in all demographic groups. No white, no blacks, all, okay? All grades of hypertension as well. So they are a wonderful group that we use frequently. Preferable to beta blocker and ACE inhibitor in blacks and older persons, okay? There is a preferential indication for calcium channel blocker in blacks and older persons. Adverse drug reaction include headache, peripheral edema, bradycardia, constipation, especially with verapamil in older adults, and the dihydropyridines are more likely to produce symptoms of vasodilatation, headache, flushing, palpitation, peripheral edema. there's an information saying that if edema developed, it will be minimized if we could co-administer an ACE inhibitor or ARB. And another very important one is that the amlodipine is the only calcium channel blocker with established safety in patients with severe heart failure. A wonderful drug that we quite often use. Again, another group, diuretics. For hypertension, thiazide diuretics are the most commonly used diuretics, as mentioned in their lecture, and they achieve most of their antihypertensive effect at lower dosages, or like 12.5 mg of hydrochlorothiazide or equivalent for other members. But we might also use them at higher doses if plasma potassium is above 4.5 millimole per liter, because as we know, they will help to decrease this potassium level. Loop diuretics should be reserved for use in patients with kidney dysfunction. They are the most efficacious diuretics, so we might use them if the kidney is not performing well, like serum creatinine over 2.5 mg per deciliter and GFR less than 30 milli per minute, in which case they are more effective than thiazide. Relative to beta blockers and ACE inhibitors, diuretics are more potent in Black and older individuals. Again, relative to beta blocker and ACE inhibitor, we didn't say calcium channel blockers, because calcium channel blockers are also effective in Black and all demographics, including older individuals. They are also more effective in obese and other subgroups with increased plasma volume or low plasma renin activity. So, this important statement shows us which preferential indication of diuretics or which groups are more likely to benefit from diuretics than others. Long-term thiazide administration also decreases and mitigates the loss of bone mineral content, as we discussed in the lectures of diuretics, so they are also preferred to be given for hypertensive females at risk of osteoporosis. Overall, diuretics administered alone control blood pressure in 50% of patients as monotherapy, but might be used effectively in combination with all other agents like calcium channel blockers. They are also useful for lowering isolated or predominantly systolic hypertension. Okay, this is another important statement for those who are suffering from isolated systolic hypertension or predominantly systolic hypertension. Diuretics are effective. What about the adverse drug reaction? Hypokalemia, but uncommon for the recommended doses, as also said in the lecture of diuretics. We might also add potassium-sparing diuretic to prevent hypokalemia, especially in those liable to the complications, like those who are receiving digoxin or with a history of ventricular arrhythmia cannot afford an episode of hypokalemia, so either potassium supplements or potassium-sparing diuretic should be given on those special categories, high-risk patients. Thiazide diuretics also might cause hyperglycemia, and as compared with ACE inhibitors or ARBs, diuretic therapy is associated with a mild new-onset diabetes, more common, slightly higher incidence of mild-onset diabetes, yet this has not made it as a contraindication to use thiazide diuretics with diabetics, because the risk-benefit ratio is for favor of using diuretics if indicated. Okay? The potential to worsen diabetes because of this hyperglycemia is outweighed, the ratio is outweighed by the advantage, the risk ratio outweighed by the advantage, by the benefit of blood pressure control. So should not be withheld from diabetic patients, should not be contraindicated to diabetic patients if the indications are for giving diuretics and we believes that other adverse effects for other groups should make diuretics of a choice for these groups. They might cause also hyperuricemia, hyperlipidemia, but again lower incidence if we are giving the low dose. Erectile dysfunction, skin rash, and photosensitivity, especially because diuretics are, most of them are sulfonamide derivatives and contraindicated as discussed in the lecture of diuretics in sulfonamide severely allergic patients. For potassium-sparing diuretics, spironolactone can cause breast pain and gynecomastia in men, enlargement of breast, because they act on progesterone receptor, an effect not or less seen with the more specific eplerenone. Hyperkalemia is also induced by potassium-sparing diuretic by both spironolactone and eplerenone, mainly in patients with chronic kidney disease, and especially more likely if plasma potassium pre-treatment plasma potassium level are over 4.5 millimole per liter, then we should not add from the start potassium-sparing diuretic. We might even use higher doses of thiazide. A new group, which is beta blocker. Beta blockers, we have traditional one like metoprolol, bisoprolol, and third generation beta blockers, nebivolol and carvedilol. Third generation because they have an extra property, extra beneficial properties in management of hypertension and other disorders like increased release of nitric oxide in case of nebivolol or additional alpha blocking action in case of carvedilol. Beta blocker decrease the heart rate, decrease cardiac output, decrease the renal release, and because of this decrease of renal release from the juxtaglomerular apparatus, they are more efficacious in population with basal elevated higher plasma renin activity. Those are younger white population. They also neutralize the reflex tachycardia caused by vasodilators, and especially useful in patients with associated conditions that benefit from cardioprotective effects of these agents, like hypertension and angina, hypertension previous MI, stable heart failure. And for stable heart failure, we have carvedilol, we have bisoprolol, we have metoprolol with specific guidelines to prescribe, as well as those with migraine headache and somatic manifestations of anxiety. For those people, beta blockers might be of a choice, and for those people we should consider beta blockers first before we consider other groups. But because of the lack of efficacy in primary prevention of MI and inferiority compared to other drugs in prevention of stroke and left ventricular hypertrophy, traditional beta blockers should not be used as first-line agents in treatment of hypertension without a specific compelling indication. Again, we should not use them as first-line agent in treatment of hypertension except if we have a specific compelling indication, as we said in the previous slide. If we have these conditions, like active coronary artery disease, then we should consider beta blocker as of a choice. Otherwise, we have groups of drugs that have shown survival benefit, and this is the most important thing we look at. Adverse drug reactions of beta blockers, you know, we have been told that we have selective beta 1 blocker, we have non-selective beta blockers, but let's stick to the basics. We also have been told at higher doses, at higher dosages, all agents, all beta blockers are non-selective, so take care of the dose. It might exacerbate bronchospasm, especially in predisposed patients. It might cause bradycardia or AV block due to sinus node dysfunction or inhibition in AV conduction. They also cause nasal congestion, sometimes Raynaud phenomena, because of unopposed action of adrenaline and noradrenaline on alpha receptors. Central nervous system manifestations like nightmares, excitement, sometimes depression, confusion, have also fatigue, lethargy, bile dysfunction might also occur. We have also alpha blockers like prazosin, terazosin, doxazosin. These agents are effective as single therapy in some individuals, but their main problem is tachyphylaxis, rapid tolerance during long-term therapy. Unlike beta blockers and diuretics, they have a good action that they do not affect the serum lipid level. Indeed, alpha blocker increase the HDL cholesterol while reducing total cholesterol. Finally, we have arteriodilators, direct arteriodilators, hydralazine and minoxidil. They relax vascular smooth muscle and produce peripheral vasodilatation. When given alone, they stimulate reflex tachycardia, causing headache, palpitation, fluid retention. So when we give those arteriodilators, we give also a diuretic to prevent the fluid retention and beta blocker to prevent the reflex tachycardia. And this triple combination is reserved for refractory cases of hypertension. The adverse drug reaction for hydralazine, lupus erythematosus-like syndrome, and for minoxidil, hirsutism, and marked fluid retention. Again, these potent agents reserved for the most refractory of cases, and we are talking about systemic minoxidil because most of you know minoxidil topical application for treatment of androgenic alopecia, but minoxidil in hypertension is given systematic as hydralazine in the most refractory cases of hypertension, and these are our references including very updated textbooks. Thank you very much. Any questions are more than welcome to be addressed at my email or at my office, and you're always more than welcome to call me at any time. Thank you.